Hello, and thank you for joining this OncLive TV peer exchange. This expert panel discussion will focus on minimizing toxicities while maintaining efficacy in renal cell carcinoma, with an emphasis on case study reviews and practical considerations. My name is Robert Figlin, and I'm a professor of medicine and biomedical sciences, chief of the Division of Hematology Oncology at Cedars-Sinai Comprehensive Cancer Center in Los Angeles, California. Participating today on our distinguished panel are Nizar Tannir, Associate Professor and Deputy Chairman, Department of Genitourinary Medical Oncology at MD Anderson Hospital, Houston, Texas. Sumanta Pal, Assistant Professor, Genitourinary Malignancies, Co-Director, Kidney Cancer Program, Department of Medical Oncology and Experimental Therapeutics at City of Hope Comprehensive Cancer Center. Brian Rini, Professor of Medicine, the Cleveland Clinic Lerner College of Medicine, Case Western Reserve University. Daniel George, Associate Professor and Director of Genitourinary Oncology at Duke Cancer Institute in Durham, North Carolina. Thank you again for joining us. Let's get started. The focus of this peer exchange discussion is to review the role of targeted therapies in the treatment of metastatic renal cell carcinoma. Recent advances in targeted therapies have revolutionized the clinical management of RCC. Tolerability and management of side effects for patients receiving targeted therapies are paramount to their implementation in the treatment armamentarium for renal cell cancer. Moving forward, future directions and unmet challenges will focus on improved understanding of the genetic basis of RCC. While several FDA-approved targeted agents have been approved for the treatment of patients with advanced kidney cancer, further genomic studies such as whole genome sequencing, gene expression patterns, and gene copy number will be required to gain a more complete understanding of the genetic basis of kidney cancer and of the biologic pathways, and to provide the foundation improving drug development in RCC. Let's look at some of the general questions and practical considerations facing clinicians in the treatment of metastatic kidney cancer. Let's start our discussion with Brian talking about the role of first-line regimens in kidney cancer and how one chooses which agents to use. Brian?
Thanks, Bob. So this is a complex question that's obviously undergone a lot of evolution over the last decade. When I'm sitting across from a patient with newly diagnosed metastatic disease, most of them have undergone nephrectomy. And what I often talk to them about is sort of the categories of drugs and try to give them at least a little bit of insight of how the drugs work. I sometimes touch on old immunotherapies, especially if they're a high-dose interleukin-2 candidate. If not, then I move into targeted therapies and mostly focus on the anti-angiogenic therapies. Me personally, and at Cleveland Clinic, we've tended to be big sunitinib users. And the way I explain it to patients is that it's an oral drug, so there's convenience for the patient. We can talk about the clinical data. My personal opinion is that's still supported by the strongest clinical data. And honestly, it comes down to our comfort level in giving the drug, which I think goes a really long way in knowing when to dose reduce, when not to, when to think about changing schedule. My nurses are experts in managing side effects. And so it's a comfort level, and we know how to get patients on that therapy, get them to a point where they can tolerate, and get them to that first scan to see if we're helping them.
So and it sounds like you have a team approach to managing patients in the frontline setting. You talk about your nurses, you talk about your staff, and it's not just you making that decision, but also the comfort level of your ancillary staff to help you manage those patients throughout their course?
Yeah, definitely. I mean, I think our nursing support is key, simply because these drugs have side effects. Whatever drug you choose, there are going to be side effects that are going to be unique to the patient and some that are general. And so having a team that understands those side effects and knows when to react quickly, how to react, how to support those patients is critical.
Dan, do you think that your practice at Duke differs in any way from how Brian approaches patients, or are there special populations of clear cell patients that you might treat differently?
I mean, it's pretty much the same. We just do it a little bit better. But no, just kidding. No. I think the reality is that this is absolutely an academic environment. So one of the advantages we have is sort of the resources of a large multidisciplinary team. Brian mentioned the fact that most of the patients had undergone nephrectomy, but we do see patients who hadn't yet. And there too, having a clinic where we have our surgeons side by side, I can walk next door, talk to one of our kidney cancer surgeons about the case. They can bring a case to me. We can kind of have that sort of real-time tumor board interaction. I think that's really helpful in being able to handle particularly some of these cases where we're discussing nephrectomy in a very kind of efficient manner. And that's really important with those cases. They tend to be a little bit more accelerated in natural history. So we want to make decisions efficiently. We want to be able to move that patient through and then ultimately get them on systemic therapy sooner rather than later. So there's real advantages to that.
So one of the questions, Monty, is in practice, I often worry that maybe the practicing physician isn't seeing the patient frequently enough, especially when starting them out on a new targeted agent in kidney cancer. What's your practice in terms of how often they come back when you're just starting out, how often they see either you or your ancillary staff? You know, sometimes, for example, sunitinib is a 6-week schedule, but when do you see the patient next when you start them on these oral drugs?
That's a great question. And, I tend to see these patients relatively frequently up front, perhaps have them come back 2 weeks after starting systemic therapy, then at 4 weeks, and then we space out the intervals to a monthly basis. But I agree with you. Seeing patients through their first couple of weeks very closely on therapy is absolutely key, and it's an important time to capture the occurrence of adverse events.
And we're going to circle back and talk about this in a few moments, but just I want the three of you to just speak to, can I assume that your regimen that you begin, sunitinib, is basically the standard package insert 4 and 2, 50 milligrams PO?
So
Brian?
I tend to be pretty dogmatic and start people at 50 schedule 4-2. Again, we're going to talk about some alternative schedules. I haven't moved to do that outside of a study, although I know many people have. And I usually, another point is I always tell patient, listen, the first several weeks, maybe a couple months are going to be an adjustment period, both for the patient and for us to figure out what are your side effects, how do we manage them, is this the right dose, and give them a little heads up that there is a little hurdle to get over here before hopefully we settle into a nice long disease control period.